So, before we go any further, you need to understand that all patients going for procedures must sign an informed consent. It is the physician's responsibility for explaining the surgical procedure and having the patient sign the consent agreement. The nurse does not have the patient sign any informed consent because the nurse is not the one performing the surgery. So, it's up to the physician. If the patient signs the informed consent and then has questions later, it's up to the nurse to get in touch with the surgeon so that he or she can answer those questions specifically about the surgery that the patient has questions about. So we have that signed, the surgeon had that signed, the patient can sign as a witness, the nurse can sign as a witness, but the patient has to sign that informed consent in front of the physician. So before the patient goes into surgery, there are things that the nurse needs to think about. So you need to be thinking about what are some physiological or psychological problems that may increase surgical risk for this patient. So does the patient have any underlying physiological problems such as breathing problems? That's our number one concern in surgery, breathing, airway, breathing, circulation. So does the patient have like COPD or asthma or anything that affects the respiratory system? And then psychological problems. I don't know if you've ever had any surgery, but it can be scary. So the patient might be having increased anxiety, increased second thoughts about the surgery. So you as a nurse need to be aware of all of these that could increase risk during surgery. So we want to teach the patient and the family about what's going to happen before, during, and after the surgery. Mainly, we're teaching the patient about what's going to happen after the surgery because we want to inform the patient of what he or she is expected to do when they come back to the floor or when they go home. Of course, as a nurse, we're worried about getting the patient out of bed, getting their lungs working, increasing the circulation in their body for great healing. So we are going to be teaching the patient exercises before they even go into surgery of what they're expected to do post-operatively. We don't want our patients to wake up from surgery and not know what they're expected to do to heal from the surgery. So we need to do all of this before. We're going to take our time so we don't overwhelm the patient so that they have all the information and they're ready to go as they wake up. So you as the nurse want to make sure that a health history has been obtained and a physical examination has been performed. And right before the patient goes into surgery, you want to take a last set of vital signs because this is going to be the baseline for the surgical team. So you as a nurse, of course, you need to know the patient's age. You need to assess the patient's usual level of functioning so that we can identify if there's any decrease in functioning when the patient comes back from surgery. Of course, we want to look in the mouth. We want to check for any loose teeth, any dentures, any plates, because these can come loose during anesthesia and they can cause a choking hazard for the patient. So we're always looking in their mouth. We want to assess their nutritional status and needs. Of course, if they're having surgery, we need to make sure that they have all of the tools available for them to have a speedy recovery. So we need to make sure to look at what they're eating before surgery and what the plan is for them to eat after surgery. Fluid and electrolyte imbalance, this is very important because any abnormal fluid and electrolyte reading should be relayed to the surgeon ASAP. So you're going to get a baseline set of labs very soon, right before the surgery. We want to know if the patient has any drug or alcohol use because if the patient is a chronic alcohol user, he or she could go into DTs. And with a drug use, if the patient uses opioids, maybe they need a little bit more pain control than what was first thought. Of course, we're always worried about their respiratory and cardiac status, especially when going down to surgery. And we need to know what medications could possibly complicate this. So I have this mnemonic down here for you. Can I do anesthesia? So this is a good way to remember the classes of medications where it kind of raises a red flag that you need to do some more investigation. So adrenal corticosteroids. So we know that corticosteroids cannot be abruptly stopped. they need to be tapered off. We don't want any cardiovascular collapse on the table. So we need to make sure if they're on corticosteroids, how long have they been on it? Are they trying to get off the steroids? And if they are, have they been tapered down? Diuretics. Thiazide diuretics may cause excessive respiratory depression during the anesthesia administration, so we need to make sure are our patients on any diuretics. The antibiotics, mycin. Drugs such as neomycin, sometimes streptomycin, might cause problems with muscle relaxation. So this could actually result in apnea due to respiratory paralysis during surgery. So any antibiotics, you need to make sure that the surgeon is aware. And then insulin. You need to understand the interaction between anesthesia and insulin. So NCLEX loves to ask questions like, you have a diabetic patient, are you going to give the patient insulin before he goes down to surgery? Well, if the patient has been NPO, which most likely he is, and he's not going to eat for the next 5 to 6 hours, it probably wouldn't be a good idea to give insulin because you're probably going to bottom your patient out. So just make sure that the surgeon is aware that the patient is diabetic and that his insulin has been held. So all surgical patients have labs very close up to the time of their surgery, and these are baseline labs. So we need to make sure that they have been completed. And we need to review the labs to see if there are any lab findings that are concerning. So the most common types of labs you're going to see are a complete blood count, a CBC, and then your fluid and electrolytes, your electrolytes. So make sure at least those two are done, and then any other labs that were ordered, make sure that they have been completed. If not, the surgery might have to be postponed. So with the CBC, we know that an elevated white blood cell count can indicate an inflammatory process. So of course, any elevated WBCs need to be told to the surgeon. Any decrease in the white blood cell count suggests maybe a viral process going on. So anything with the white blood cells, either they're too high or too low, you need to report to the surgeon. Of course, we're going to look at the hemoglobin. If the hemoglobin is too low, we know that this impairs with tissue oxygenation. So this is important to let the surgeon know. The patient might need a blood transfusion. And an elevated hematocrit may indicate dehydration versus a decreased hematocrit, which might indicate fluid overload. So I would look at the white blood cells, the red blood cells, the hematocrit, and hemoglobin, and make sure that those are all normal values. So here are the CBC labs, the normal ranges for hemoglobin. Males is 13 to 17 and females are 11.5 to 15.5. If you want to think of this as like when males and females hit puberty, anything to memorize these labs. So, you know, females hit puberty about 11, males about 13. Hematocrit normal ranges, females 40 to 55 and males 40 to 55 and females 36 to 48%. And then the platelets, NCLEX loves to put platelet counts on there for you. So just know that the normal platelet count is between 150 and 400. And then the white blood cells, the normal range is 5,000 to 10,000. So the way I remember white blood cells is that kids between 5 and 10 usually come home from primary school with a lot of illnesses, viruses, infections. So just remember that white blood cell count, the normal range is 5,000 to 10,000. Now, of course, your electrolytes, you want to make sure that they're all within normal limits before they go into surgery. So sodium is usually 135 to 145. Some books may say 136 to 144. I wouldn't be too concerned. I would keep the 135 to 145 in mind. Of course, anything far below that or far above that needs to be communicated. Potassium, remember we learned that potassium K, we think about cardiac, heart. So the normal value is 3.5 to 5. Of course, with potassium, anything too low or anything too high, because we're thinking about the heart, needs to be relayed to the surgeon. Magnesium, we have 3.3 to 5.3. Remember, this has to do with muscles, muscle contraction. So make sure that that's within normal limits. Calcium, same thing, 2.1 to 2.6, muscle contraction. And then your phosphate, chloride, and bicarb, these are the normal values. You're just going to have to memorize this, but bicarb is really important in differentiating, as we learned, between metabolic acidosis and alkalosis. So make sure that you understand what the normal values are. So nutrition. Does the patient need to be NPO before the surgery, and has the patient been NPO? It's really important if you come in on the day shift that the patient hadn't been eating all night. It's up to you to verify that. If the patient did eat or had food snuck in from a family or friend, you need to notify the surgeon ASAP. And then, of course, the patient is diabetic. We talked about this, but you need to check the glucose reading. Of course, if the glucose reading is 400, you're probably going to give insulin, but if we're not going to be feeding the patient, if the patient hasn't been eating, their glucose should not be too high. But if it is and you have to give insulin, notify the surgeon. So we need to teach patients what to expect before they go into surgery, so that we don't want any surprises when they come out of surgery. So if they're going to come out with any drains, if they're going to have to use an incentive spirometer, if they're going to have a PCA at their bedtime, if they need to be in a special position, we need to let them know this so that they don't wake up and have more anxiety because they don't know what's going on. So this is going to make the recovery process easier for the patient, easier for the nurse, because everyone's on the page of what needs to happen. So some pre-op nursing diagnoses that you need to be concerned about. So anxiety related to the surgical procedure. Many patients have anxiety related to the pain that they might experience. So you need to educate the patient on how the pain will be controlled, what scales you're going to use to monitor their pain level, what their ideal pain goal is, and be realistic with that. So if they're having major abdominal surgery, maybe a pain goal of 0 is not realistic, but if we can say a pain goal of 2 is probably more realistic, then we have somewhere to start. Then we have risk for ineffective therapeutic management related to not knowing the preoperative procedures and protocols. So this, again, is just up to the nurse to teach the patient what's going to happen before they go to surgery and after they go to surgery. So make sure your patient knows any labs that they need to get, that they're on NPO, they can't even have water. If they're doing outpatient surgery, what time to arrive, what to expect when they're in the pre-op area, and of course what to expect when they wake up. So a lot of patients might have fear related to the actual surgery itself. Maybe they're fearful that they can't see their friends or family. So again, this is something that needs to be talked through with the patient. Make sure that the patient understands how long they're going to be separated from their family or friends, so that the patient can make plans if they have children or anything like that. And then, of course, the not knowing exactly what's going to happen during the surgical process. This is what the surgeon will discuss with the patient when he's getting the consent form signed with the patient. So, more interventions for the pre-op nurse. So you need to provide psychosocial support. You're going to be worried about their anxiety, about their fear of being in pain. So you need to be a good listener, you need to be empathetic, and you need to provide information that helps decrease those responses. You want to give the patient time to ask questions and be acquainted with those who are providing care during and after surgery. So, of course, the patient has met the surgeon. Usually the anesthesiologist calls the patient the night before to introduce him or herself and to go over those questions again on any medications they're on, make sure that they're NPO. We want to acknowledge the patient concerns and listen therapeutically and try to alleviate any of those concerns the best way that we can. So our job is to worry about the fear, the anxiety, and then of course we're going to talk about cognitive strategies that the patient can use to relieve their anxiety or relieve tension. So we can teach relaxation, imagery. Doesn't matter what we teach, anything to get that patient off of their fear and anxiety related to the surgery. So of course, before the surgery, we want to provide adequate nutritional support all through the day of the surgery. So If the patient's allowed to have protein, we want to make sure that they have protein in their diet. This is great for tissue repair. They're going to need that after surgery. Again, make sure that they understand the NPO process and how long they need to be NPO. And sometimes physicians allow clear fluids up to 3 to 4 hours before surgery, but this is based on the type of surgery and the surgeon. So all of that is kind of varies if they can have a small meal or a little bit of fluids. If your patients are dehydrated, we want to make sure that we have an IV site and we're giving the patients fluids via IV so that they don't become dehydrated. And of course, with our patients with chronic alcoholism or any malnutritional issues, we need to make sure that the patients who are alcohol dependent are not going to go into withdrawal. We don't want any DTs after the surgery, during the surgery. So with alcoholism, just know that they usually have malnutrition, and we need to make sure that they're not going to withdraw the day of surgery. Of course, we're going to urge our patients to stop smoking. Again, with surgery, we're concerned about ABCs, airway, breathing, circulation. So we want our airway to be as healthy as it can be. We're going to teach the patient how they're going to be doing breathing exercises when they wake up. So we're going to introduce them to the incentive spirometer before they go to surgery. And of course, we're going to assess any underlying respiratory illnesses. So assess their current respiratory status, make sure that they're taking medications appropriately to keep their respiratory status working as well as it can. With a patient with cardiovascular disease, of course, we want to make sure that our cardiovascular system is stable. So we don't want to change positions suddenly. We don't want to keep a patient in bed for like a week up to the surgery. We want them up walking around. We want to make sure that they aren't hypotensive or have hypoxia. So we're going to be checking those vital signs. And of course, we don't want to overload them. We don't want to overload the circulatory system with excess fluids or blood. So we really need to be monitoring those labs and monitoring vital signs. Of course, if the patient has any underlying disorders of any organ, we need to be aware of that. We need to look at tests ordered for that specifically, make sure that the patient is healthy enough to go into surgery and has a high probability of coming out of it without any further damage. So again, if our patient's diabetic, we're going to monitor the blood glucose levels. And remember that mnemonic I taught you about, the red flags of medications you need to be aware of if the patient is on them before surgery. So here are just some more organ issues that you need to worry about with the patient. So you need to be aware if they have any thyroid disorders. You need to let them know if they're going to be in a special position, like I said, after surgery, or if they're going to be moved from different positions to positions after surgery. If they're going to need any special positions where the nurse is going to have to monitor them in those special positions. But again, our focus should be on breathing, airway, and circulation. So of course, after surgery, we want our patients up, walking around, expanding those lungs, pumping that blood throughout the body. So we do want, exercises of the extremities, keep everything moving around. And then of course, body mechanics, when you are moving patients from a gurney into a bed or from a bed into a gurney, you want to maintain the patient's proper body alignment so that you don't strain any muscles or tendons of the patient. So remember, every person is an individual, so we need to work with every single patient maybe in a different way to identify their individual needs. Of course, we begin teaching as soon as possible, so way before the surgery actually happens, so we have time for the patient to express any fears, any questions. We can teach them what to expect after, so we don't just go in and dump all this information on the patient an hour before surgery. This should have happened over a couple days to allow the patient to come up with any further questions and to really understand the process of what's going to happen. So again, how you teach the patient is going to be very individual based. So you want to provide information via written materials as well as speaking to the patient We talked about that return demonstration, especially with, insulin. But if there's anything that you need the patient to understand how to do after surgery, it's great to tell them about it, give them something to read about. They might enjoy a video about it. So understand how that patient learns the best, and then try to provide that patient the educational materials in their best form of learning. And then, of course, again, reinforce if they're going to wake up with any drains or tubes, they need to be aware of this so they don't have more anxiety when they wake up. And then let the patient know when family and friends are able to come visit them after the surgical procedure. So some patients might not be coming from, the hospital unit into the surgical center. Some patients might be having ambulatory surgical procedures where the patient comes in for the day, has surgery, and goes home. So we need to make sure that the patient is aware of what he or she needs to do at home before coming to the surgery center. Again, we're going to educate them using whatever means we need to, verbal, written. They can watch a tape about it, a video. You could tell them about any group meetings that might happen that talk about, patients who have had the same surgery. We're going to answer any questions. And we need to be very specific about telling the patient where and when to report. Make sure they know where they're going. Make sure they know what to bring and what to leave home. So we usually tell patients don't bring anything like jewelry or contact lenses or anything that can get lost. So leave all that at home, and we want them to wear loose fitting, comfortable clothing because we're going to put them in a gown. So then, of course, we're always going to stress NPO, 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 so they can brush their teeth before they come into surgery, but nothing to eat or drink by mouth. And again, before the procedure, we're going to talk about the patients, how to promote lung expansion, especially after anesthesia. So we're going to teach them about how to take deep breaths, deep and slow breaths, and how to exhale slowly. We're going to teach the patient how to splint the incision line to minimize pain over the incision line when they cough and deep breathe. And then we're going to educate the patient on the medications that are available to relieve their pain, that they should be taking, every 4 to 6 hours, or PRN when they have breakthrough pain, or right before they're doing their breathing exercises. So, of course, we're going to tell the patient to take their medications, their chronic medications, like they do every day, unless the physician has said not to. And we're going to talk about any pre-medication that might happen before the surgery. And, of course, we're going to assess the pain level of the patient before the surgery, because if they're having pain before the surgery, it might be to anxiety. We need to pre-medicate them so they don't come out of surgery with even more pain. A lot of hospitals these days have the patient bathe in a germicide for a few days at home if they're coming from home. This is to decrease the bacteria on the skin and to decrease the risk of infection during the procedure. If hair needs to be removed, it's usually removed by the nurse right before the operation using electric clippers. So the patient doesn't have to shave. Let the patient know that the nurse will shave him the morning of the procedure. We're going to have a patient in the hospital gown. We're going to leave it open in the back, and we're going to put the patient's hair up, and we're going to put a cap over it because we don't want their hair to be, intertangled with the anesthesiologist back there trying to give medications. And then right before, we're going to inspect the patient's mouth. We're going to take out any dentures or plates because that can be a choking hazard for the. So if the patient does have objects that we need to take off, make sure that you remove them and you put them in a safe place. It's best if family takes personal items home so that there's not a risk of them getting lost in the procedure. Make sure that the patient voids right before the surgical procedure. And of course, if there's any pre-anesthetic medication ordered, we need to make sure that the patients get those as ordered. We want to, of course, keep them safe if we're going to give them medication. So we're going to keep the bed rails raised, and we're going to be monitoring our patient to make sure that the patient is continues to have an open airway and is able to breathe on his or her own. So if the patient is going to surgery from a hospital floor, you need to make sure that you send the complete chart with the patient to the operating room. Do not send the patient without the chart because you'll have to go back and get it. You want to attach the surgical consent form and all the laboratory reports and any last minute information that you need to let the surgeon know about to the front of that chart. So make sure that the chart goes, the most recent CBC electrolytes are on there. Any patient allergies need to be clearly stated on there. And any concerns that you have, make sure that that's clearly stated and written for the anesthesiologist or the surgeon to see. And if usually somebody from the hospital will take the patient down to the pre-op holding area, make sure that they're settled, ready to go, make sure that they've handed off the patient to the next team, and then we wait for the patient to come back for post-op. So on that checklist, this is just a checklist for you to keep in the back of your mind, or you can print it out. So you want to make sure on that chart you have any allergies identified, the informed consent is on there, the patient does not have any last minute questions for the doctor, the labs are complete and they look good. If they were not looking good, you would have contacted the surgeon before. There's a complete head to toe assessment done and there's no concerns with that. The NPO status was started and abided by. All pre-op medications were given as ordered. The glucose reading, it was checked, and what was it? No medication concerns that the patient is currently on, no jewelry. We checked in the mouth, no loose dentures, no loose teeth, and the surgical site is marked, checked, and easy to see. Now you can't check the surgical site too many times. You know, in the hospital they have the timeout in the operating room where everybody stops to make sure it's the right patient, the right surgery on the right area of the body. So if you want to mark the area of the body just for your own comfort, that's fine. The surgeon's probably going to do it on his own as well, but just make sure you clearly understand what procedure the patient is having and it's clearly